Okay, the recording has started. Welcome to the CCBC Common Read presentation. Today we have Vanessa Varacalli, Colby Jones, and Anthony DeStefano. Vanessa holds a master's degree in psychology with a specialization in crisis management. She has over 13 years experience in the mental health field. Vanessa is currently the Assistant Residential Director of Behavioral Health for the Allegheny and Beaver County. Colby holds a master's degree in health administration and is currently pursuing a doctorate in health administration, and is a certified leadership development coach with over 14 years experience in the mental health field. Colby is the behavioral health community-based outpatient director for both Allegheny and Beaver County. And Anthony holds a master's degree in criminology, a master's degree in business administration and healthcare management, and is certified with the National Association for Duly Diagnosed, with over 15 years of experience working in human services. Anthony is a regional director responsible for operational oversight of DDTT services, supporting Western Pennsylvania and Ohio. Okay, so I'm going to turn it over to you now. Go ahead.
Okay, good afternoon, everyone, and thank you for the opportunity to speak with you all today. We have presented here just a snapshot of Merakey. It's we're prefacing it as more of a high-level overview of the programs that we offer locally to Beaver County, but also have some information here that we can go over that just gives a broad overview of who Merakey is, what we do, and you know how we work to improve the lives of all the individuals across the continuum of care in human services. So with that, again, my name's Anthony DeStefano, and I've been with Merakey for quite some time. And I'd like to start today by just giving just a brief history of the organization. Merakey is an organization that started in Pennsylvania, actually started in Philadelphia, the Philadelphia area, and over the last 50 years has expanded to not just include all 67 counties in the state of Pennsylvania, but we've added a number of different states, all the way across the country to California, where we're providing dual diagnosis services and intellectual developmental disability services for the entire state. Our organization is rather large in the sense that we employ almost 11,000 employees at this point. We work with over 50,000 different individuals and families every year, with a wide range of programs that we offer, from behavioral health to children and family services, intellectual developmental disabilities, residential services, community-based services that are specific to veterans. And more recently, Merakey has now acquired its own pharmacy. So now we're able to provide that pharmacological assistance to all of the individuals that are a part of the Merakey continuum of care. Just a little bit more about Merakey. Several years ago, for anyone who's been in the field for a while, and especially in Beaver County, we've been in Beaver County for many, many, many years. We actually started out in Philadelphia as Northwestern Human Services. And over some time, as we expanded, we moved into NHS Human Services. And we were just trying to rebrand at that point in time to make the name a little bit more recognizable. And more recently, in the last 3 or 4 years, we've rebranded again to now Merakey. And we utilize the name Merakey because it's a derivative from a Greek word that Merakey, that means to pour your heart and soul into what you do. And it was a huge initiative on our part because we really wanted our name to reflect what it is that we do. And every single day we pour our heart and soul into the work It doesn't matter what division we're in or what service we're providing. It was an excellent opportunity to showcase in our name what we do every day. So with that, there's just some information here in this slide about our mission and our vision statement. Our mission is enriching lives by providing exceptional services through an individualized approach. And that's something that we implement through our core values of safety, trust, compassion, integrity, quality, and diversity. All of which are a part of our day-to-day operational and clinical approaches to working with the individuals, as well as our strategic focus for growing our services moving forward. So with that, we're going to talk through a variety of different programs. Again, we're going to try to keep it localized. These are the programs that we offer in Beaver County at this point. And we just wanted to put out there, if there are any questions as we're working through this, for those of you that are participating out there, feel free to raise your hand. Feel free to drop a chat, and we hope to have more of a dialogue if possible. But if it's more comfortable to save your questions towards the end, that's also fine. I think we have some time allotted to have some discussion based off of the information we're going to go over here today. So with that, I'm going to turn things over to my colleague Colby, who is going to talk to us about our community-based programs that we offer in Beaver County.
So good afternoon, everyone. So yes, I wanted to point out some of the community-based programs that we have available in Beaver County. First is our drug and alcohol case management program. This program supports adults 18 and older with primary diagnosis of drug and alcohol, and they provide linkage and support in the community resources. So this isn't so much of a treatment type of service. It's more of a linkage. So this program also works within the Beaver County Courthouse, the Beaver County Jail. So this is one that will be specialized for individuals that may need additional support with drug and alcohol services. The next one is our blended case management services. So blended case management supports transition age youth 16 to 18, and then also adults 18 plus. The primary diagnosis for this program is a mental health, and what they do is also some linkage, but they also help them create independence in the community through the same type of resources. They support with housing, outpatient, group therapies, things like that. This is also not a treatment-based program. It's a linkage and case management-based program. The next program that we have is our forensic assertive community treatment team. This treatment team also serves adults 18 plus, but the difference with this community treatment team is they provide services to individuals that identify with having a severe mental health diagnosis and also need some forensic support. They provide intensive wraparound community support because they utilize a whole team approach with mental health professionals, housing specialists, nurses, peer specialists, and a psychiatrist. So an individual that would have this type of support would have access to all of the different levels of support that this program provides. And then next we have our dual diagnosis treatment team, and I will send that back over to Anthony to talk a little bit more about that program.
Thanks, Colby. Yes, dual diagnosis treatment team. I happen to be a regional director there, so I thought I would be more appropriate to kind of go through this. So what we've talked about so far in our community-based programs, talking about linking resources, talking about specific niche populations, folks that are suffering from substance abuse, or the forensic population, folks that are in and out of the criminal justice system. Merakey has also, over the last 10 years, been developing a proprietary approach to working with dually diagnosed individuals. And when we say dually diagnosed, most folks think of mental health and substance abuse. And in this case, we're actually talking about dual diagnosis in the sense of intellectual developmental disability and mental health. And this is a population that has presented in the state of Pennsylvania, in the state of California, in the state of Ohio, and I'm sure it's the same across the country, a very complex treatment and support approach because of the severity of the intellectual developmental disability combined with the severity of severe and persistent mental illness. This population creates a lot of stress for the system at large. So our program is designed to address, to the best of our ability, the needs of these individuals. And one of the specific instances of addressing this population, or our outcomes, let me say that, is diversion. A lot of times this population will find themselves in and out of a psychiatric inpatient or at risk of losing their housing or their community tenure because their behaviors are so severe, and because the program that may be supporting them just doesn't have the resources, the skill set, the education, or the patience at this point to work with them. So dual diagnosis treatment team is designed to work with those folks that are taxing the system, and we do it in a way that is comprehensive. It utilizes the assertive community treatment model that Colby just referenced with our forensic ACT team, but it's niche for this population, and it's a lot more intense. There are several variables that we provide this intensity through. It's a short length of stay. It's an increase in the number of interactions that these folks have during the week. Our team, and we'll show you here in just a second another slide with just some additional information. Our team is made up of subject matter experts that you don't typically find in a community-based program that are able to see individuals where they are, meet them in their own environment. And we also we keep our caseloads very, very small. So the idea here is to wrap around this complex population, provide them some stabilization, and then at the same time transfer skills to the natural supports. It could be mom and dad, it could be the group home staff, it could be a neighbor, it could be a relative. We got a lot of folks that live on their own that we work with, and it could be that we have to find them a natural support. But the idea is to transfer skills to that group of folks so that they are able to, succeed when DDTT leaves. So I'm not going to read down through every bullet on this slide. You guys have this for your information, but I do want to talk a little bit about the overall approach of DDTT. Our program is comprised of its own psychiatrist, its own psychiatric registered nurse, its own pharmacological consultant, its own behavior specialist, its own mental health technicians and service coordinators. And that in itself is impressive for a population in a community-based program in Pennsylvania. But then again, as I said, we wrap around these individuals very intensely. Our caseloads are very small. We provide the services in the natural environment. We are assertively finding these folks in the community. We go to them. We are time limited, and it's a shared caseload where it's not my caseload, your caseload, and we answer to a program director. We share the caseload, and we talk about every single individual every single day. What did we do yesterday? What are we doing today? What are we doing tomorrow? And we really try to make sure that we're a fixed point of responsibility so that everyone that we interact with is speaking the same language. A lot of times, for anyone that's working in the field or planning to work in the field, a lot of times individuals that are very complex can come to us with a variety of different individuals, different services. There may be a primary care physician involved, a neurologist involved. There might be medication managers involved, other case managers from the county level. There sometimes 15 to 20 different people can be coming to us with this individual referral. And most often, they are not all speaking the same language. They're all kind of just doing their own thing, and no one's working on the same goals. So DDTT can help with that as well. We make sure that everyone is working on the same treatment and support plan. And then finally, our crisis management is probably one of the biggest parts of our program. And you see this a lot in our drug and alcohol programs, and even in the FACT program, the forensic assertive community treatment program. we provide a 24/7 crisis response to individuals. So in this case with DDTT, we're specifically providing that for anyone who's in crisis the entire time they're with us. And the point of that is to divert from hospitalization, to reduce readmissions into the inpatient situation, to reduce the reliance on crisis from a county perspective or local law enforcement, but also at the same time to transfer skills. You know, there are a lot of examples, and you know, if we have some time, we can talk about them here, where you know, folks think they're in crisis, or the natural supports feel it's a crisis, and it's really not. And we can show them how to manage and de-escalate behaviors and situations. So there were a couple of questions that came in, so I'm going to stop there for a second and try my hand at seeing if I can't figure this out. Okay, so we had a question: have you encountered an increase due to coronavirus in the number of people who need services? If so, how are you addressing this increased need? That's an excellent question. So the coronavirus over this last year has presented a number of challenges in the human services world. Everything we just talked about here is community-based. It requires us to be face-to-face. Requires us, you know, pre-COVID to be there when they need us. Even, you know, we're talking about crisis management. And it's been a challenge to figure out how to make that work and how to support those individuals through a telehealth modality, which I think we've been able to do quite successfully at Merakey. It's one of the advantages of being a big organization with a lot of experience. We've actually been doing telehealth for many years prior to the COVID pandemic. But to answer the question from my perspective, and then I'll turn it over to, you know, Vanessa and Colby to provide some backup, I do see an increase in the need for services, and for different reasons. You know, there are a lot of folks that are in the same boat as the rest of us who are sitting home. They're not allowed to leave. They're not allowed to engage in community, you know, activities. Movie theaters, you know, the malls, the public outings that a lot of the folks in the intellectual developmental disability world rely on as part of their community integration processes and just in the activities of daily living. Those have all been shut down, and those create behaviors. Those create anxieties, and those can exacerbate mental health diagnoses, as well as intellectual developmental disability diagnoses and substance use disorder. I think we've seen that across the board. Substance use disorder is up. It's increased. You know, people are consuming more alcohol. People are really feeling it. Now, I think we'll start to see that come down, and I'm no expert in COVID, and I'm not going to pretend like I am, but I think we're going to start to see some of that relax as we are able to move back into our community-based programs and address these situations. But I you know, from the perspective of dual diagnosis treatment team, where we come across the gambit of diagnoses and circumstances, we have seen an increase in the need for services. And the way we address it is we just do the best we can. When we can see folks face to face, we go. I mean, we're healthcare workers. We use our protective equipment. We have our face masks, double face masks, shield, and goggles, and we go and see folks. But when it's not okay and it's not comfortable, then that's when we start to rely more on our telehealth modalities, which CMS has you know, opened up, and the state of Pennsylvania here has opened up for us through the Office of Mental Health and Substance Abuse. They've been pretty good about allowing us to be flexible with it. So, but I'll turn it over to Vanessa or Colby if you guys want to add to that.
Yeah, sure. So from the perspective of my case management programs, we have seen an increase in the number of people who need the services, but we also experienced a barrier to being able to get to those individuals with coronavirus. Well, it's not seeming to be so much of a barrier now, but in the beginning, you have facilities and organizations closing their doors because of COVID, and not just being a lot stricter with whom they're letting in, and how people can begin to receive some of those services. So our referrals come from a lot of the detox programs, come from hospitals, come from different facilities. So as those facilities are slowing down their intake for people coming in, as that affected, referrals to our program. So that's a barrier that we've seen. But a need for increase in services, absolutely. So the good thing now is that we were able to work through that, through the relationships that we developed with some of the other organizations, and we're now on a better route to being able to serve those individuals that still need that case management support in the community. So I'll turn it over to Vanessa to let her speak on some of the residential impact.
Hello. So yeah, I would definitely agree with what they're saying. I think the benefit to our programs and from a residential standpoint is that, almost all of our programs are somehow the wraparound programs like Anthony was talking about, and also 24/7 crisis. We've definitely seen an increase. I don't have the numbers in Beaver County, but in Allegheny County, sometimes people are waiting in the hospitals a year to get into an LTSR. And we'll talk about that in a minute, but it's a locked unit, and they need that level of care, but they're waiting a long time because of some of those, similar barriers. We have definitely seen an increase in, the anxieties and things like that our residents have sometimes on a daily basis, or just the struggle to understand why can't they go out, why can't they walk up the street and go to, a place that they used to go to all the time. So to answer the question of how we're addressing it, sometimes it's 24-hour crisis, and we're there every day, and we're there with them and getting them through it. So, all right.
And Vanessa, there was another question that came in. I'll read it, and then maybe we just go backwards. Start with you,
Okay.
and then go to Colby, and then I can chime in. So the question is telehealth challenging to use for individuals in need of services? Are you seeing a digital divide, or is this not a barrier?
So I can definitely talk about that from a residential standpoint. It is definitely a barrier. A lot of our residents have that persistent mental illness. They are extremely paranoid about, cameras and those kind of things. And so we have to really tread lightly. Sometimes they just refuse. And, in our services, they have that ability. So we try not to push it as much as we can. Our psychiatrist does come to them. So we have that. And I like to say that, the LTSRs are kind of a one-stop shop. We have everything we need. And if we need to bring them somewhere, we can. It's been a definite barrier with families and some of the community-based, our residents do have CTT and FACT and things like that follow them, and they can't always see those people. And so that's definitely a barrier.
So I would say for case management level, yes and no. We, have definitely been utilizing telehealth, and there is a divide at times. There's individuals that work off of, the amount of data that they have. So utilizing video is not going to be feasible because they just don't have the data on their phones to be able to do it. But a lot of our individuals do have cell phones and other ways that we can get in touch with them. So more so of a barrier of engagement from our case managers. It was a little difficult at first. You're used to seeing someone face to face and having that engagement. Now you have to flip that engagement to talking to somebody over the phone. And, a lot of times the individuals we're engaging with don't really want to talk that long. Doesn't feel very intimate at times. So we went through a lot of engagement training with our case managers and how to make sure that they're continuing to keep those individuals active and engaged in services while we're going through this period of telehealth. So I will say that the training has been very beneficial to our programs to try to get over some of those barriers.
Yeah, and I'll just add to in the experience we're having in the programs that I support. I mirror Colby and Vanessa's barriers because we do work in a residential facility sometimes, and we work in the community sometimes through dual diagnosis treatment team implementation. And there's also the addition of just those natural barriers of, Pennsylvania is rural. I mean, the majority of the state is very rural. So having access to the internet, having access to cell phone service, where you can have these telehealth opportunities, that's just a natural barrier that I think we're all challenged with at this point. And hopefully someday we can get that infrastructure to the rest of the state that we have, that you would see in downtown Pittsburgh. Although I've heard that it's not that great in downtown Pittsburgh either at times. So I just think there's, it's worth saying, and also the ability to use the technology. You can have the technology, and when you're working with the intellectual developmental disability population, they rely a lot on folks that are supporting them to help them with that technology. We've been able to provide it. There's lots of grants that came through with the CARES Act and local county funding. I think we ended up getting some iPads. I think it was like 24 iPads at the onset of the pandemic that we were able to distribute to folks so that we could make sure that we had eyes on them. And I think, that was half the battle, is getting the technology in their hands. A lot of folks just don't have it. They don't have the ability to purchase it. So when they're able to provide it, then you have to start working through, okay, do they have access to the right network? Do they have the ability to turn the machine on? Is anyone there that can help them, navigate through it? So I think we've done it well, though, as well as we can. From a human services perspective, we collect a lot of outcome data on just, what type of interactions we're having. Are they telephone interactions? Are they telehealth interactions? And our data looks pretty good from our overall perspective as an organization. But that's because, again, we have that savviness, we have that ability to pull on resources and the wherewithal and the subject matter expertise. There are a lot of smaller providers that may not have that ability, and it's most likely impacting them, probably more so than us. But another question came in, and then I promise you we will get to the residential programs that Vanessa will give us an overview for. But the question is, who funds your services? Is it insurance, government, grants, donations? Do clients have to qualify? So I'll start. The majority of the services we provide are Medicaid funded in the behavioral health world, in the adult behavioral health world. And with Medicaid funding in the state of Pennsylvania comes a relationship with managed care. Managed care is a system that Pennsylvania has adopted that provides oversight of Medicaid funding to ensure that it's being utilized appropriately. It's a system that came into play about 20 years ago here in Pennsylvania. And for all intents and purposes, it works really well. Each county or region of Pennsylvania is contracted with a managed care organization. And then that organization is responsible for meeting the needs of the population of that region that they support. And through that, they have what we call medical necessity. So when we talk about do clients have to qualify, each program is, at least in adult behavioral health, is managed through what we call a service description or a contract. Better term would be a contract. And in that contract, there are very specific guidelines that we have to adhere to that are approved and reviewed on a regular basis by state regulatory agencies. Some of our programs, like you're going to talk with Vanessa here about LTSR and personal care homes, they have a whole set of regulations that are enforced by the state of Pennsylvania. In addition to the managed care's expectations and program standards, and then in addition to what we impose on ourselves in building out a model. And through all of that, combined with medical necessity and the service description, that's how we are managing and implementing our services. The funding is primarily Medicaid, but there are other forms of funding that come through. If we're talking child welfare services, there's funding that comes through in what they call it Schedule 4E funding. It's federal funding. There are county contracts that we hold where the counties are able to utilize their own tax dollars to facilitate a program or to contribute to a program. But primarily it comes through that Medicaid funding. And then again, a qualifying indicator for Medicaid is that individuals have to qualify for the managed care Medicaid, which is typically held for lower income individuals that are suffering from mental illness or intellectual developmental disability or substance use disorder. Those are the folks that you have to have some of that need in order to qualify for the as well for the services. But Colby and Vanessa, anything to add to that one before we move on to residential programs?
The only one funding source that I want to add that my programs, the case management programs, do see support from is grants. So there are a handful of smaller grants that we do utilize in Beaver County for case management.
And for the LTSRs and personal care homes, Anthony hit the nail on the head. There's not really much different, even though it's IDD or DDTT, it's still the same adult behavioral health. We get random donations sometimes, but for the most part, it's exactly, what he said. So. All right, so I guess I'll go. So I assist all the residential programs in Allegheny and Beaver County. In Beaver County, we do only have the LTSR, but at someday we're hoping to have the personal care homes also. So I didn't want to leave that out. So the LTSRs is also has to have that severe and persistent mental health diagnosis. They can have the co-occurring, but they have to have that major mental health diagnosis first. We are an adult program, so I always say 18 to 85. Some people will say, how old can they be? As long as they don't need nursing care, they can be in our facilities. And as I said before, the LTSRs are the wraparound. We have everything that they need on site. We provide the crisis management, the management of symptoms, managing their medications. We have nurses, the psychiatrist comes here. We do group and individual therapy, the discharge planning. The discharge planning piece of it, we incorporate some of those outpatients. So if they had DDTT or some of the services that Colby was talking about, we would, add them in there. We invite those people to treatment teams. And it's really just an overall, whatever that client needs, it's also a team approach and a person-centered approach. So whatever that individual needs is what we try to provide in collaboration with the community and family supports if they have any. And then the personal care home, like I said, we don't have them in Beaver County currently, but that is essentially the LTSRs just in the community without the treatment piece to it. So they're more daily living, but it is geared towards adults with mental health and that severe and persistent mental health diagnosis. So it's permanent housing for them to have safe housing once they leave places like LTSRs and things like that. That's it.
So the rest of the slides that we have here are just an overview of some additional services. Merakey does have an intellectual developmental disability division that focuses specifically on IDD individuals and their needs. And here's just a few of them that we offer. Allegheny Valley Schools is a part of Merakey. It's just one of many programs across the organization that we facilitate through shared living, in-home supports, employment services, working with folks to just give them a better quality of life, give them opportunities to be able to be productive and enjoy, activities in the community, or if it's a vocational situation, behavior supports, focusing on how to better support individuals that do have behaviors that may not be at the point of, a DDTT level of care, but there are behaviors and we do need to have maybe a restrictive procedure in place for safety. And it all goes back to making sure we're not violating anyone's rights. You know, folks that are in the IDD world have the same rights as every one of us. And, you know, Merakey has been doing this for a very long time with that population and is very good at being able to advocate for individual rights. And again, to give them that quality of life that they deserve. And then we also have a variety of other IDD community and facility-based programs like drop-in centers or home and community rehabilitation. You know, we have folks that will engage with individuals, take them into the community and let them, you know, express, you know, whatever interest they have and help support them in meeting those goals that surround that interest. And then one other slide here is we just wanted to add, you know, Merakey, one of the things that we're really proud of because of our longevity in the field and our subject matter expertise in each of these areas on the continuum of care and human services. You know, we like to toot our own horn a little bit about some of the certifications and accreditations that we have. So we are National Association of Dually Diagnosed accredited. We are CARF accredited. We are COA accredited in multiple programs. And for anyone who's thinking about entering the field or is currently in the field, you know, I don't know who out there is listening. Those accreditations are significant, and they are a testament to how programs are effectively and successfully promoting outcomes for this population of folks that we work with in, you know, the human services world. And, you know, outcomes are a big thing right now in human services, in healthcare and behavioral health, where, you know, you're going to start seeing a lot of focus on HEDIS measures, you know, those healthcare indicators that folks are really worried about from a tax-based perspective. How are we spending our Medicaid funding? Are we using it to prevent people from being hospitalized? Are we using it to prevent people from recidivating in the forensic system? So these accreditations are a testament to how we're able to achieve some of those more national outcomes. And then you have our contact information. If anyone would love to hear us continue to discuss, I could tell you right now for DDTT, I could talk probably 4 or 5 hours straight about that program. It's one of the most innovative things that we have. And I'm sure Colby and Vanessa could do the same with our residential and other community-based programs. And then the rest of our slide deck here, and we'll share it with our facilitator here to make sure that everybody has access to it if you want it. It's just another overview of information. It really just gives you a high-level bullet point, all the things that we do in each of the divisions within the organization. And you literally could find this on our website, but we know that sometimes having it right in front of you, you know, makes it a little easier than having to go look for it. So with that, I'll go back to our website. So in case anyone wants that. That concludes our formal presentation, and we'll turn it over to you guys if anyone out there has any questions. I appreciate your questions along the way too. I don't know, Stacy, if there are folks that we want to call on or.
Thank you so much for your presentation, Anthony, Colby, and Vanessa. So now you have the opportunity to ask questions. Rose or Amanda, do you have any questions?
Hi there, I do not at the time. You guys gave a great presentation with a lot of detailed information, so you kind of answered some questions I was having along the way during the presentation.
Rose, do you have any further questions? Rose asked, are clients referred by PCP or caseworkers?
So I can kind of start from the residential perspective. Our clients are referred. The LTSRs are a locked unit, and so they are referred either from a case manager or an outpatient provider or an inpatient provider. We get, clients from Torrance State Hospital, from the local hospitals, as well as from the community. So it really just depends on what the need is at the time, and they have to be sent here either through probation or by the court system. Because they're typically here on a commitment.
And for case management programs, they can be kind of referred from any source. A hospital, a PCP can refer. They can also self-refer. The only catch, well, I don't want to call it a catch, but the only thing is that they need to make sure that they have a recent evaluation from a doctor. So even if it's a self one, if they talk with their PCP or they talk with someone and this is the level of service that they need, all we need is a copy of that information, because their diagnosis is what identifies them and allows them to be a part of our programs.
Yeah, and I would just add, to Colby and Vanessa, and as you heard, it's really program specific on how a referral is made and received by each program. It kind of goes back to that medical necessity piece as well, and eligibility for Medicaid if it's a Medicaid funded program. And typically when there are Medicaid dollars attached to the program and the individual receiving the service, there is some sort of county or state case management or supports coordination that occurs. And that's typically where you would see a lot of referrals. The PCPs are able to make the referral, but at the end of the day, it's the folks that are paying for the service that actually have to make the decision on whether or not this person is eligible. So a lot of our contracts, not all of them, but a lot of them have a referral process where the payer, the managed care organization or the county, or they're the gatekeeper of the referral process. But we always welcome referrals directly to the program, because we know that we can go right back to the counties and say, hey, we got a referral, what do you guys think? And it keeps keeps it from bottlenecking, for lack of a better term, with those one or two folks that might be managing these types of referrals in the county, state, or managed care organization. Another question came in, is it by residential facility, do you mean in a house or a hospital? So I will kick that over to Vanessa.
So we try to make it as homey of a place as possible. So back when the state hospital started to close, they realized that there were still people that needed some of that inpatient care, and it might not be long term like the state hospitals were, but shorter term, but still considered long term. And because of that, they opened LTSRs, at least in Pennsylvania. And so the idea is that they come to our facility, they get what they need, but they live in a home setting. So in Beaver County, if you walked in, you wouldn't necessarily know that, there are offices in the back that have therapists. They have big screen TVs and things like that, to make it feel comfortable for them. They have their own bedroom. Some of them share a bedroom, but it looks like a home. So, because that's we want it to be safe and comfortable while they're with us until they move on to their next living situation.
Are there any other questions? Rose wrote, thank you. And yes, I thank you too. Thank you so much for your very informative presentation. As I previously mentioned, since this presentation has been recorded, I know it will have a long-term impact on the students, faculty, and staff at CCBC. Thank you so much.
You're very welcome, and thank you for letting us have this opportunity to talk about us and what we do and the people we serve.
And thank you for all those that attended as well.